As Melanie said, today we're going to talk about optimizing your EndomeTRIO results. So I'll get a quick introduction of our agenda. We're going to start with proper patient selection, i.e. the indication for ERA, EMA, and ALICE, applying the correct cycle type and timing, taking the biopsy correct as far as processing and handling at the clinic, applying properly the clinical directive of the ERA, EMA, and ALICE results, utilizing clinical support offered by Igenomix, and lastly, reviewing your clinical data. So first, let's do an introduction of the complete view of endometrial health that we have to offer at Igenomix. We'll go test by test, starting with ERA, of course, where we look at the receptivity of the endometrium by analyzing 248 genes and their expression. The EMA test, endometrial microbiome metagenomic analysis, where we look at the microbial health of the endometrium, specifically lactobacillus, pathogens of the reproductive tract, including those associated with chronic endometritis. And then our ALICE test, analysis of infectious chronic endometritis, specifically looking for those bacterial pathogens associated with chronic endometritis. We do have the EndomeTRIO test, which includes all three of those tests combined with a single endometrial biopsy, again, getting a complete view of endometrial health. So let's talk about proper patient selection, i.e. indication for our endometrial test. Starting with ERA. ERA is specifically indicated for patients with recurrent implantation failure. We know that this particular group has an increased risk of a window of implantation displacement, about 1 in 3 of these patients. There's many publications showing statistically improved clinical outcomes, specifically for patients with RAF, when applying a personalized embryo transfer cycle, something we refer to as a PET, that's guided by the ERA results. As I mentioned, supported by both internal and external publications, not only retrospective study, but prospective studies, and more recently, a meta-analysis. When we talk about the RAF population, we're talking about the more difficult population. These are patients with years of infertility where we've exhausted other options, such as PGT, for example. So these are the patients who can truly benefit from endometrial receptivity analysis. Now moving on to EMA and ALICE, our microbiome test. This is useful for patients with recurrent implantation failure, as by a paper we published back in 2016. Also for patients with recurrent pregnancy loss. For this reason, we've seen patients with recurrent pregnancy loss and recurrent implantation failure have a risk of chronic endometritis with prevalence rates up to 60%. We can also apply this to women who have suffered intrauterine infections of previous pregnancies and those who suffer from pathologies that can increase the risk of having infections of the reproductive tract. As I mentioned, EMA does include testing for chronic endometritis, which is generally an asymptomatic disease. Thus, women are often not detected to have this particular endometrial pathology. So assessing the microbiological environment can help identify the pathogens and treat the patient prior to embryo transfer. And this has been supported by publications from Igenomix, specifically the ones I have up from 2016 and more recently 2020, in which the findings show that pathological modification of the endometrial microbial profile is associated with poor reproductive outcomes in IVF patients. And lactobacillus has been found to be consistently enriched in patients with live birth outcomes. So how do we apply the correct cycle type and timing when performing ERA, EMA, and ALICE? Well, let's start with ERA. So with ERA, there are 2 cycle types that are valid for this test. The first is HRT, or hormone replacement therapy. That is the preferred cycle for ERA. Being that you have the more control and you're able to replicate it much easier than, say, a natural cycle. In this case, the biopsy is taken after 5 full days of progesterone, which equates to 120 hours of progesterone exposure. In a natural cycle, the preferred method is with HCG trigger. However, the biopsy can still be taken by monitoring LH surge. In this case, the biopsy is taken on either LH+7 or 168 hours from HCG administration. Now, a few things I want to emphasize here. You must select the same cycle and protocol in both the frozen embryo transfer cycle or the PET cycle and the biopsy cycle. So we can't use, say, an HRT in the biopsy cycle and then use a natural cycle in the PET cycle. So we do see this from time to time. Maybe the patient's lining wasn't building and the physician converted her to a natural cycle. But in those cases, the results wouldn't be able to be carried over. So that's very important that everything is replicated exactly. The only thing that we're changing here is progesterone exposure time if indicated to do so by the results. Secondly, we must properly control for endogenous progesterone. This is an absolute. So we know that the initiation of the plasma membrane transformation is due to even just small levels of progesterone. So measuring endogenous progesterone within the 24 hours prior to the first intake of exogenous progesterone will help us ensure that their endogenous levels are low enough not to start that plasma transformation and hence initiate the beginning of the window of implantation. If that happens, then we can have an artifact in the results since we don't really know when the first progesterone exposure started. So it makes the results not useful. We must also sure to replicate endometrial condition. So in the terms of endometrial thickness, endometrial pattern. So let's say in the mock cycle, your patient had an endometrial thickness of 7 millimeters, but then in the transfer cycle, she was 12.5 millimeters. This may affect the reproducibility of our findings, again, hindering the results of the test. And then very importantly, as I said, there are 2 cycle types approved for ERA, HRT and natural. But please note, ERA is not validated for use in ovarian stimulated cycles because we know the effect of supraphysiological hormones on the window of implantation. Now moving to Emma and Alice. So these are only for Emma and Alice. Now, you can use the same protocol used for ERA, which we recommend the same timing. So HRT or natural based on HCG trigger or LH surge. Or if you are only performing the Emma and Alice test, you can opt to take in a patient's natural menstrual cycle between days 15 and 25, as long as they have normal cycles between 26 to 32 days. And then actually quite popular here in the US, we see a lot of cycles taken while the patient's on OCPs. If you are taking the endometrial biopsy for Emma and Alice while the patient's on OCPs, you want to take between days 14 and 21 of active pills, or day 14 and onwards if only active pills are used continuously without placebo pills. With that said, not all birth control options are going to be a viable option for Emma and Alice. So we need the endometrium to be under the influence of both estrogens and progesterone, since we know that this represents the most stable time for the microbiological environment. In that case, the birth controls must contain both those hormones. We do have a list on our website that is continually growing with approved OCP options. Now, most importantly, the endometrial biopsy for Emma and Alice must always be taken in the secretory phase, as again, the microbiome has been shown to be more stable at this time and also represents the time of transfer. So this is when the implanting blastocyst will reach the endometrium. Now moving on to proper biopsy handling and processing at the clinic. So when performing the biopsy, so we want to make sure that you clean the vagina and cervix with sterile gauze. I bring this up because we see a lot of times clinics will use betadine to prep before taking the biopsy. This should be avoided as it could contaminate the sample and affect the integrity of the RNA, causing it to degrade, leading to an invalid RNA result. It's also important to avoid introducing any fluid into the endometrium. When performing the biopsy, a small endometrial biopsy should be taken from the uterine fundus using a Pipelle catheter or similar. We only need a very small amount. In this case, more is not better. So 70 milligrams will do. This corresponds to tissue with size of about 7 millimeters. And too much or too little tissue can be an issue. So too little obviously can lead to insufficient RNA results since there's not adequate RNA to analyze the test, where too much tissue can lead to invalid RNA because what happens, it overwhelms the RNA stabilizing buffer in the ERA cryotube. So the RNA is not stabilized, it degrades, and then we get a profile that's not useful. The endometrial biopsy should be transferred to the supplied cryotube containing that RNA later, that stabilizing buffer. We want to make sure we don't expose the sample to any other fluid, so it's not necessary to wash the fluid before introducing it into the ERA cryotube. And it needs to be immediately refrigerated at 4 degrees Celsius for a minimum of 4 hours. So this part of the process helps with stabilizing the RNA before shipping. Now, with my experience as ERA, especially in the US, many times I'll kind of investigate if we see a high invalid RNA result, for example. And sometimes we find that maybe if the sample's taken to the surgery center, it'll stay on the counter for an hour until they can go back to the clinic and put it in the fridge. This, again, should be avoided. So within 10 minutes, that sample needs to be refrigerated. We also want to avoid transferring an excessive amount of blood and mucus into the cryotube. So again, this can lead to non-valid ERA results. And when EMA and ALICE is being performed, antibiotics should not be used within the 7 days prior to biopsy, during the biopsy procedure itself, or after the biopsy until results are obtained, since we know that antibiotics can affect the endometrial microbiome. So we want to understand what that microbiome exists without the influence of antibiotics. Now, applying properly the clinical directive. So I have an example here of a letter that was published by Cho et al. In 2018, and it just demonstrates further the validity of the ERA and the reproducibility. In this particular paper, they question the reproducibility of the ERA test result in one patient. We could see here that the first biopsy was taken at 106 hours, in which our recommendation was to rebiopsy 48 hours later at 154. But instead, the authors took a second biopsy several days later at 194. The result was still post-receptive, obviously. We said to then take a biopsy 24 hours earlier. They took a third biopsy, still post-receptive. Essentially, after 4 biopsies, 2 of which were unnecessary, we could see that the last result coincided with our initial recommendation for PET. So this was a letter that we responded to, thanking the authors for, again, showing the reproducibility of the ERA results from month to month, but again, also showing the need to express that ERA is not a treatment, it is a diagnostic tool. The success of using this diagnostic tool, i.e. the treatment, lies in the patients and the clinics to apply it appropriately. So this was a perfect example of following the clinical directive can be beneficial for patients. Now, specifically to the ERA and the PET cycle, as I said, it's important to replicate the ERA mock cycle and the PET cycle. So this includes the protocol, so cycle type, including all medication. We want to avoid progesterone rescue. So this is something that we've been hearing a little bit more chatter about. If the blood levels right before transfer are not a progesterone level that the clinic thinks is where it should be, they'll give a progesterone rescue dose. Now, this could affect the reproducibility of the results. So we don't recommend giving that progesterone rescue dose until after the transfer has occurred, because we've properly transferred the embryo during the window of implantation. Uterine conditions also need to be replicated. That includes pattern and thickness. So the ERA can be performed in a trophic endometrium if this is the patient's usual morphology. And then any interventions that the patient needs should be taken care of before the biopsy. So we want the endometrium to be in similar conditions between the mock cycle and the transfer cycle. As I mentioned before, we need to control properly endogenous progesterone and then follow the recommendation provided by the ERA report, transferring in that plus or minus 3-hour window. Applying properly clinical directive for EMA and ALICE. So apply the results of EMA and ALICE tests properly. This includes personalized treatment versus broad spectrum antibiotics. So this is a huge advantage of molecular testing for endometrial microbiome, specifically for bacterial profiling, because you can see which bacteria is present and out of normal range, allowing you to provide a guided and personalized treatment for patients. So you'll find on the second page of the EMA and ALICE reports a list of antibiotics along with which bacteria they are effective against that you can use in guiding your treatment, depending on the bacterial profile obtained. We also want to transfer in the cycle immediately following the biopsy or treatment. So this is ideal. So we'll take the biopsy, get the results, potentially treat, and then want to transfer in the next cycle because the microbiome can shift over time due to factors such as sexual intercourse, antibiotics, hormones, hygienes, etc. We want to avoid prophylactic antibiotics. So I know it's common to give antibiotics prior to transfer, but imagine that we just treated a patient, restored her lactobacillus, and then we gave antibiotics right before a transfer prophylactically. We could be wiping out again that lactobacillus population, which she just spent time and money replenishing. And then speaking of lactobacillus, proper replenishment of lactobacillus population using vaginal probiotics consisting of lactobacillus only. So far in the US, we have one commercially available brand that can be found on Amazon. We've also worked with Rosemont Pharmacy, which is a fertility specialist pharmacy, to formulate probiotics, specifically with Emma and Alice. And then test of cure. So this is up to the physician in the clinical practice, whether there's a test of cure, especially if antimicrobial therapy is used. So now I'm going to go into a little bit, maybe not as obvious, but certainly ways that you can optimize your endometrial results that I think are imperative. One is utilizing the clinical support offered by Igenomix. So at Igenomix, we are the experts and innovators when it comes to endometrial testing. This has been in our DNA for a long time. With that said, we have dedicated endometrial researchers. We do have an endometrial medical team consisting of medical doctors, scientific advisors with PhDs in reproductive genetics, clinical microbiologists on staff, and certified genetic counselors. Most publications and studies pertaining to endometrial receptivity with transcriptomics and endometrial microbiome and the molecular level are coming from Igenomix ourselves. We have specialized tools for clinics, such as the PET calculator, which I show here. If you haven't been privy to this, it's a lifesaver because you essentially put in when the patient needs to transfer. You can enter the progesterone start time. It will tell you when they should transfer, or you can put in the ideal transfer time and it'll tell them when to start progesterone. So this is certainly a helpful tool. So you're not writing it out on paper and trying to figure out, okay, what is 120 hours from today? We have ongoing education and certification programs to offer, and continuous introduction of clinical trials and opportunity for research collaboration with clinics. Now, the last part, also not as obvious, but is certainly essential in order to optimize your results, is to review your clinical data. At Igenomix, we do have a clinic portal dashboard that gives you your statistics in real time. So you can look at, see what percent of my patients are coming back pre-receptive, what percentage of my patients are coming back post-receptive. And we can compare that against what our global rates are to see how you're performing. We also do have the ability to collaborate with clinical follow-up, collection, and reporting, in which we would send you a list of your cases, whether that be ERA or Emma and Alice. You can provide us with the clinical data, and we'll create a 2-page ERA clinical report that not only compares your receptivity rates towards the global receptivity rates, but also your clinical rates with your ERA results. So here, it also gives us the ability to pinpoint areas for improvement. Are we replicating cycles exactly? Are we controlling for endogenous progesterone? And are you following the clinical directive? So this will really allow you to fine tune the tests in your own hand and really optimize the best results for our patients. So with that said, that brings me to the end of the presentation. I thank you all for attending.